Good day friends. Today I am going to talk to you about redefining obesity care. We realize that obesity is a complex disorder, it's multifactorial, and in this presentation the first part we will talk about that. The second bit we will talk about physiology of weight regulation and followed by novel medical approaches for management of obesity. Now traditionally obesity has been defined on the basis of body mass index, and internationally it is thought that a BMI greater than 30 taken as a cutoff of obesity. There are several ethnicity specific cutoffs of obesity BMI that have been used, but in recent time we have realized that obesity is more than what a Taylor measures. It is a complex chronic disease in which there is abnormal excess body fat, and this excess body fat leads to health related problems, complications which need medical treatment and reduces the lifespan of an individual. In the past, people were more hell bent about that number, that is the BMI. We now realize that if you are talking about management of obesity, you have got to talk about the complexities of the problems that the patient faces, and it has to be a patient centric management that we have to look at. Again, in the past we had thought that obesity was a simple problem of energy balance. That means what you earn in terms of your energy intake, that is your food intake, and what you spend in terms of your energy expenditure. So it was thought like that any imbalance in this will lead to obesity, and we realized that the major organ systems involved in obesity was the adipocytes, the pancreas, the gut, but we now know there are several environmental drivers and of course genetic factors which are important in the pathogenesis of obesity. Now when we talk about obesity and its complications, you can actually classify it into three subtypes, that is the metabolic complications of obesity, which include diabetes, hypertension, dyslipidemia, gout, fatty liver, gallstones, infertility and cancers. The second is mechanical bits of obesity, including sleep apnea, chronic back pain, knee pain in terms of osteoarthritis, physical dysfunction, gastrointestinal problems and asthma, and finally the effect of obesity on the brain, that is the anxiety and depression. These are all complications of obesity. Now having talked about the multifactorial pathophysiological basis of obesity and the complexities, let us talk about physiology of weight regulation. Now when we talk about weight problems, we have got to realize that essentially even if you have an energy imbalance of a very tiny amount, there will be problems, and the entire neurohormonal factors which are involved in energy homeostasis starts from the taste sensation, the gut, the food intake, the brain and all the hormones in the gut, the pancreas, the fat and as well as the neuroendocrine system. And the first bit is when we are talking about appetite. Now why do we eat? The most important reason we eat is what is called homeostatic regulation of appetite. That means you feel hungry because you want to preserve normal bodily function. So your body functions normally, and this hormonal bodily homeostatic regulation is regulated by the gut, the pancreas, the adipocytes and the hunger. So the first bit of appetite regulation is called homeostatic regulation of appetite. The second bit is the hedonic eating. That means you will find that you want to eat a packet of crisps. You might not be hungry at that point of time, but you are having it because when you eat it, you have pleasure. This is the pleasure of eating, or this is what is called hedonic appetite. Now when you are going to say a wedding invitation party, you will eat initially because you are hungry. Secondly, you will eat because you like some of the food items. For example, you are wanting to have more of the dessert. Now you will see that some of us will be able to control ourselves and skip the dessert knowing that I have already eaten enough calories, and others will not be able to control it and they will overeat. This third component of regulation of appetite is the executive function to decide to eat or not to eat. So, you realize that when you are eating, you are essentially having three components of your appetite. One, you are eating for your homeostatic functions to be normal, to survive. Secondly, you are eating because you feel happy, and the third is you are deciding whether you eat or you do not eat. Now, when you talk about the weight loss challenges, whatever we do in terms of our weight loss program, you will see a lot of people will go for, say for example, diet, rigorous exercise. People will go and join the gym, they will manage to lose some amount of weight. But what unfortunately happens is, after they have lost weight, after a while, once the zeal of the diet regulation and the appetite and the exercise and physical activity pattern goes, people will invariably regain weight. So, you might have lost a lot to start with, and then you will find that you are coming back to the baseline. So, why does this happen? Is it that these people who are doing this are very lazy people? No. When you diet, when you change your dietary habits, when you are over exercising to lose weight, there are certain compensatory changes that happen in the body. Dieting activates certain compensatory biological mechanism, as a result of which you start feeling more hungry. So, it is even more difficult to suppress your appetite. And in the past, when you were eating whatever you were eating, you were feeling a sense of fulfillment or satiety. That degree of satiety also goes, and the body lowers its basal metabolic rate, so that there is a reduction in energy level, and the brain actually seems to like having food, even those food stuff which it did not like eating in the past. So, these compensatory mechanisms actually help in regaining the weight that you have actually lost. So, over a period of time, therefore, it is not surprising that whatever diet you try, whatever form of non-pharmacologic therapy you try, it is bound to fail. So, is there a better way of managing obesity? Because if you look at whatever form of drug therapy you are looking at, it should help you in weight maintenance. These compensatory mechanisms which were causing the weight rebound must be stopped, and that is where the role of medication comes in. So, we are now finally going to talk about novel medical approaches of obesity management. Now, I have already talked about the three bits of control of appetite. The first is homeostatic eating, the second is hedonic eating, and the third is the executive function. If you are looking at drugs which work at each of these levels, you will see that the GLP-1 and the satiety hormones and the ghrelin, they are all involved in the pathway of homeostatic regulation of appetite. So, if you are using GLP-1 drugs, you will find that the homeostatic eating will be suppressed. Whereas, there have been drugs in the past, for example, that you have been using, for example, rimonabant, which were working on the hedonic aspect of eating. It was good in a way that it was suppressing your appetite, but it was causing also depression and suicidal tendencies. The third bit is the executive function. This we can probably modify by behavioral interventions and lifestyle. Now, if we are actually looking at medication and surgery, there would be some role of bariatric surgery. But if you look at the drugs, there is only two classes of medication that are currently approved in India for weight loss. One is orlistat and the other is injectable semaglutide 2.4 milligrams. However, that has still not been marketed, and the indications for drug therapy is obesity with a BMI more than 30 kg per square meter, or being overweight with a BMI of more than 27. Now, these guidelines are Western guidelines. In an Indian setup, the cutoffs will be lower. Now, what do the GLP-1s do in terms of its regulation in appetite? The GLP-1 is secreted from two sides, that is the L cells in the gut and in the brain from the nucleus tractus solitarius. It has got effects on the pancreas, the brain, the gut and the heart. The GLP-1 reduces energy intake and increases satiety and decreases hunger. Semaglutide is an analog of GLP-1 which does the same job as a GLP-1, and it impacts almost all dimensions of appetite intake and reduces food intake and results in significant weight loss, and it might lead to up to 10 kg of weight loss compared to only about half a kilogram in individuals with placebo. Now, there are various forms of semaglutide preparation. We have been using semaglutide tablets for the management of diabetes, but there is various forms of higher doses of oral semaglutide which hasn't been launched yet in India, and the injectable semaglutide for the management of obesity which is approved but not yet marketed. So, if you look at the dose response of semaglutide, the oral semaglutide and the injectable semaglutide have almost identical pharmacokinetic properties, and you will see that in the entire pioneer program that you are looking at, the weight loss even with oral semaglutide is pretty dramatic. Anywhere between 2.5 kg to 5 kg of weight loss happens. The STEP program has been evaluating the effect of semaglutide in the injectable form, and what was very exciting with this drug is that at least 50% of people on injectable semaglutide 2.4 is able to achieve a weight loss greater than 15%, which is pretty dramatic, and that is in all of the STEP studies, that is STEP 1 to STEP 5 program. And if you look by categories, even in various BMI categories, the weight loss has been dramatic, and what is important is, in addition to the weight loss, it leads to other benefits including glucose benefits, reduction of HbA1c, cardiovascular risk benefits and weight related benefits, all put together in one with relatively acceptable GI safety profile, though we know that we will have to look for side effects in terms of nausea and vomiting. There are several other compounds in the same category which are being processed at this point of time, and again the space in front of us looks very exciting because we are going to have newer molecules like CagriSema. Tirzepatide is also approved internationally but still not available in India. These are also drugs that would be useful in the management of obesity. So finally, to summarize, we realize that obesity is a major health problem in developing nations including India and that we need a multi-pronged attack to actually manage obesity, starting from non-pharmacological therapies like lifestyles of diet, exercise, behavior therapy, supplemented with drug therapy, the currently available drug Orlistat and the one that is coming on the way, the GLP-1 based injectable therapy, will be dramatic addition in the armamentarium of management of obesity. Thank you very much for tuning in.